All right. Good morning, everyone. We're going to go ahead and get started. Um, welcome. I am so thrilled to introduce our speaker this morning. So I'm Allison Zolba. I'm the Division Director of Adolescent and Young Adult Medicine. And we have the distinct privilege today of having Dr. Ana Radovic, an Associate Professor of Pediatric Psychiatry and Clinical and Translational Science here at the University of Pittsburgh. In the Division of Adolescent and Young Adult Medicine. Presenting, Ana also serves as Assistant Dean for Medical Student Research at the university. She is a pediatrician and an adolescent medicine specialist, having completed her training at Case Western Reserve University and at the University of Pittsburgh, including residency and fellowship here. And then we had the distinct pleasure of having her stay on as faculty, and it's been such a joy to get to be within this division together with her. Her research is incredibly timely. It focuses on using technology to improve mental health services for adolescents and young adults with depression and anxiety. She's developed a whole array of different projects and resources, including SOVA, which is a web-based intervention providing teens with anonymous peer support and reducing barriers to mental health care. Her NIH-funded research portfolio spans clinical trials examining passive sensing for depression prediction, online social support, and digital cognitive behavioral therapy for youth with sickle cell disease. She's a co-investigator on the ETUDE study, which is a collaborative effort to enhance depression and suicidality screening and care in pediatric primary care. And she serves as director of clinical research for the Center for Adolescent and Young Adult Health here at UPMC Children's, for which she was just awarded a Momentum Award from the university to help build out a research registry that's youth-centered, youth-partnered, to really improve the recruitment, retention, and participation of diverse youth within pediatric research. So I am delighted to welcome Ana to present on rewriting the algorithm.
Hey, good morning, everyone. Thanks so much for coming in person, and thanks for coming online. You can hear me okay? Yeah. Okay. And thanks, Allison, for such a lovely introduction. It is my pleasure to talk to you about this topic today. So I'm just going to check the arrows. Okay, I'm just going to use the arrows. So today I'm going to talk to you a little bit about technology and mental health. And I think I do research in this area, but it's such a kind of popular thing that comes up in our day-to-day lives and with our patients, and even thinking about how we're going to use technology clinically in the future, because it's not going away. So just think about that in mind in whatever your kind of space is in applying technology to mental health. Maybe even though sometimes getting really into the weeds with research might be a little bit intimidating, hopefully some of the things I talk to you about can be applicable in whatever space that you're in. So we're going to talk about how do we approach tech with an open mind. Oops. How do we partner with experts in the technology space, and how do we learn from and partner with youth? So I'd just like for us to pause, recognizing that suicidality is a difficult topic, and it's one that we might experience ourselves in the health professions. And so hope is there, and resources are there if you need it, including 988 crisis text line. So we know that teen mental health is a really big topic. And the thing is, it's becoming more and more of a big issue. So let me just gonna decide to look at this slide instead. So when we look at a recent study by Wolf and colleagues from 2025, looking at the past decade of data from National Survey on Drug Use and Health and Youth Risk Behavior Survey, we can see that rates of persistent sadness or hopelessness have been increasing in high school students over the past decade. And Episodes of major depressive episodes have been also increasing over the past decade, especially after COVID-19 pandemic. That was a big increase, but currently as well. And when we look specifically at suicidality, it's even more concerning. So in the late 90s, there were increased rates of suicidality in terms of the blue line seriously considering suicide and the orange attempting suicide, while the black line graph is looking at suicide mortality. And we did have some decreases in the mid 2000s, but then increased post COVID. And rates right now, in terms of youth seriously considering attempting suicide, are above 20%, which is really concerning. And attempting suicide is about 10%. Specific populations are at much higher risk. And I just want to highlight sexual and gender minority youth because the risks are really, really astounding. So when we look at the bar graph on the left, the blue bar is looking at heterosexual and cisgender youth. The orange bar is looking at LGBTQ plus youth, and then the gray bar is specifically transgender youth. And most of transgender youth and LGBTQ youth say that their mental health was not good most of the time or always, that they've had persistent sadness or hopelessness. But alarmingly, over half of transgender youth have seriously considered suicide, and 40% of LGBTQ plus youth. And unacceptably, or to me, over a quarter have previously attempted suicide. So these are really alarming rates. And if we look at why LGBTQ plus youth may not be getting mental health care, of course, things like costs are a really big issue. But then there's other really concerning things like being afraid to talk to somebody about their mental health or being afraid they won't be taken seriously. And obviously, it's a serious issue in this population. Just over the past month, the Trevor Project published results about a nationwide survey of LGBTQ plus youth and found some concerning trends around experiences they have around mental health seeking. So 90% of LGBTQ plus youth said recent laws, policies, and debates have caused them stress or anxiety. And transgender and non-binary young people unable to access hormones they wanted were nearly twice as likely to attempt suicide than those who could. So we know this is a really, 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 really big problem. And whose job is it to fix it? We can think about ourselves in healthcare settings and primary care. We can also think about schools, insurers, parents, community organizations, policy, and government. But I would argue this is a public mental health crisis. It does not make sense. Okay, so when I was going through my training, thinking about identifying depression and suicidality in adolescent medicine, it was kind of like, oh, in pediatrics, that's not what we do. We refer to psychiatry, and we're not really comfortable with this problem. And now it's just been increasing, increasing, increasing. And the rates are just going up more than you would expect with genetics and things like that. So I'd argue this is a public mental health crisis, and it's not just our problem, it's the world's problem. And globally, it's becoming a big issue. And when we look at this article by Dixhorn and colleagues out of Europe in the School for Public Health Research at NIHR, they have this really nice list of how complex this problem is. And typically we're thinking about what can we do on an individual level. So we've all been talking about trauma and how that influences mental health outcomes. We've been talking about things like identity, like I mentioned, gender and sexuality, obviously genetics and biological factors, which we can study a little bit more discreetly. But then thinking about as this person comes into our settings, they're also in a family. And that family dynamic is really difficult to intervene on, but this is really influencing their mental health. That's why it's difficult with adolescents transitioning to adulthood. Sometimes they transition and then their whole world changes when they go to college. And I've seen a lot of young people finally start to seek care or have some opportunity to seek care. And then what about their community? So a lot of work is done in our division around studying things like in the criminal justice system, violence, but then overall mental health awareness, differences in terms of location, rural versus urban, and how those settings are influencing your day to day. But then thinking more broadly about these structural factors, so we can see the rates in LGBTQ youth do not make sense. What is so different about these youth? What's different is about their lived experience in today's society, and thinking about policies and discrimination and stigma that really affect increased rates. So we can't just think that we can solve this problem on our own. But we all can do something. And I really think it's important to not think about, oh, I'm going to refer to Dr. Schreiber, he's going to take care of all these patients. Obviously, it's not, right? And we can all do something. And the things that we do with our patients day to day are really important and effective. So the key ingredient in psychotherapy is therapeutic alliance. That means I don't care what skills you have. If I come to you and I feel like you don't care about me and you're not listening to me, therapy is not going to work. And a lot of the things that we do day to day with our patients really help them feel better. And this is the common factors model. AAP just emailed recently, they have an echo where you can sign up to learn more about this. But if you think about it, it's basically what are the common factors in therapeutic methods that result in improved outcomes? And the first one is thinking about hope. Are you setting realistic expectations and talking about your patient's strengths? Well, I'm really glad that you are, 80% adherent to your med. Let's try for 90% next time. Having that empathy, which we do a really great job with, language, thinking about using the family's words makes them feel really understood. And then this one is a big one, which is loyalty. And I think we kind of underestimate how meaningful that is. Families who've interacted with the mental health system feel really let down and abandoned. And people are trying really hard to help them, but the mental health system is just not a great system. So you might lose your insurance, you might find a provider you love, and then they can't see you anymore because you can't pay for them, or there's so much complexity. But we, in our medical healthcare settings, can have that loyalty and that ongoing thing. So, oh, I told you to go see a therapist. What happened? Oh, why don't you come back and see me in 2 months and we can check in and troubleshoot together? So having that ongoing connection and relationship, and someone who's not going to give up with you when the system is so difficult can be really, really helpful. And then giving permission, so giving people permission to talk about their mental health and how it influences the rest of their care. Partnering, helping to address barriers. I don't know who can help you, but one thing I always throw out is Allegheny Family Network, which is an amazing, amazing, amazing resource we have in Pittsburgh. You just go to AlleghenyFamilyNetwork.org, and they have parent and family peer support who will use their nonprofit funds to help families navigate mental health care. So, I'll find you someone who can help you. I don't know, but I know what questions to ask. And then making a plan, kind of setting some realistic first action steps and including monitoring and follow-up. So we're not helpless, but technology sure makes us feel helpless, right? It's moving at such a fast pace that it's almost impossible to keep up with, and yet it's here. And so we have to deal with it, right? I remember when I was a resident and I was working and people were using their Palm Pilots and people were starting to use iPhones. And I'm like, this is not going to work. How is this going to catch on? I don't want to do this. But I had to, right? And here we are. And so if we look at what everyone likes to kind of blame, I showed you this really complex list of so many things that affect mental health, but a lot of the conversation is around social media. And I want you to know that some of the largest systematic reviews done only show a small to moderate association between social media use and mental health outcomes. And this is when we're looking at meta-analyses of longitudinal studies. So social media use is associated with some higher depression, internalizing, externalizing behavior, self-injurious thoughts, substance use, lower self-perception, and reduced academic achievement. But the effects are small. And when we look at it, it really depends on what you're looking at. So this study by Singh et colleagues found a U-shaped curve where actually high use and no use were both associated with worse well-being, especially with older grades. And problematic social media use, that's the type of use that is associated with depressive and anxiety symptoms. But there are mediating and moderating mechanisms, like if you're also sleep deprived, if you're using it for social comparison or to seek feedback, if you are getting exercise and social support externally, that can help. And the type of social media use is really important. And then there are things that we can do. Sometimes it feels like we're helpless against social media, but people who have real life perceived family and perceived social support, that can mediate the negative effects. So sometimes if someone is coming into you saying the problem is with my media, how can we strengthen what's around them with their family support and their peer support? So problematic addictive use, that's what is most concerning for suicidal ideation, and not time spent on the screen. It's easier to intervene on time spent on the screen. You're just like, put that screen away, stop spending hours on it. But it's really, how are they using it? Okay, so if they are saying these are some of the questionnaires in these studies, and it helps to look at some of those items, thinking, I'm using social media apps so that I can forget about my problems. This sounds similar to the craft we use for substance use. I'm using substance so I can forget about my problems. I've tried to use my apps less, but I cannot. I've used it so much it has a bad effect on my schoolwork or my job. And then we all joke about being addicted to our mobile phones. But if you really think about it, if you made an effort to put it down, if you said, I want to use this less, I'm going to use it less, could you do it? If you can't, that's when an addiction is, that you are so hooked that you physically cannot put it down. That's different. So really, and then similarly with the video games. So it helps, it hurts, it's here, it's not going away. Okay, so what are we going to do about it? So this is a fun slide. This is me taking a real selfie when I'm a teenager in my mom's bathroom, and I was doing photography classes in high school. And on the left, this is when I was in middle school, and I was ordering information from ABP about how to become a pediatrician so I could do my little report. And it came from a 1993 little booklet I got in the mail, right? But then on the right, of course, like I'm getting into doing selfies and stuff because I'm part of the Zennial generation. So we're in the middle of everything, and we know what it was like before, and we know what it's like here. And we've constantly been part of this process of changing. And teens are also the same, okay? They're not little kids, but they're not adults either. And they're constantly changing, and it's hard to keep up with them. But one thing I like to, encourage people about adolescents is that you just start with partnering with them, just being there and being available. When you partner with them and you're around, you can monitor them more. And we know some of the strongest evidence for adult influence in teens' lives is through monitoring, because through monitoring, we actually have knowledge of what's going on. And I'd argue the tech gives us some more insight into teens' lives than we used to have when they would just go off in the woods and you wouldn't know what would happen. And with that more knowledge, you can actually become an influencer in their life and influence some better outcomes. So if you're thinking about, okay, how can I use tech with whatever I'm doing with youth? The first place to start is to really learn about tech with an open mind. And even if you haven't done research before or you're a trainee, clinicians are really great at qualitative interviews because that's experience that we have. We're really good at interviewing. And you can use qualitative data. You saw some of those meta-analyses. We have to deal with numbers. Numbers are great, no offense to quantitative, but they don't give us that depth of like, what are these teens doing with their tech? And what does it mean? And how can we intervene? How can we design interventions? So qualitative data can help us look at all those different sides of the story. And then I'll give you some examples of how I've used this. So when I was a fellow, I did a qualitative interviews with teens at the STAR Clinic at Western Psych who have severe depression and suicidality about how they use their social media. And we didn't really know much then about social media use and depression. But I asked them, and they told me really interesting things that, one said, I tell on Tumblr I was thinking suicidal a little bit, and I got people saying that you have things to live for, and it's really nice and helpful. So someone was getting live suicide prevention online. And then another one said after posting status is calling for help, but no one took it that way because they thought it was just calling attention. Now, every time I see someone sad or posting, I'm going to kill myself, even if for attention, I will contact or message them and say whatever I can to help. So I learned these teens, even though they've been through so much, so many upsetting things themselves, were being altruistic, wanting that not for someone else. And we found this on both sides, right? So we found negative information and positive. So in the yellow bubbles, you can see some of the negative experiences they were having online with oversharing, with having triggering posts. One young person was talking about a band she was following, and then all of a sudden she saw pictures of self-harm that she was trying to avoid. And then there are also really positive things like having social engagement, being able to express identity, saying, that made me feel good because I was like, well, someone online in the LGBT community agrees with me, even if my parents don't agree with me, they do. And so sometimes for some youth, these are lifelines because they don't have anybody else to talk to, but they can find this supportive community online and get some hope. Another study I did more recently was with LGBTQ youth we recruited online. And as I showed you earlier, some youth are resistant to getting mental health care because of their identity. And so we wanted to learn about their experiences with online mental health seeking. On the left, you can see a quote about a young person talking about how they've talked with other people online about having horrible experiences with their therapist. No offense to therapists, but they, were really expressing how they had a difficult time where some people were outrightly homophobic, and even people who said, I'm LGBTQ friendly, that wasn't actually a genuine experience that they had. And then what we were trying to do is inform a new intervention that we thought we would have to develop from scratch. But turns out we really learned something neat, which is that these LGBTQ youth were using Discord. If you're unfamiliar with Discord, it's kind of like a Slack for video games or Teams for video games, but then turned into more of like a communities, individual communities with servers online that a lot of young people use to talk to each other. And they talked about many things like seeking medical transition, sexuality, self-harm, eating disorder, suicidal stuff. So really, 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 really deep topics that these young people were addressing online. Okay, so step 2 is to watch them use it. So you've done these interviews, they've kind of told you what they're doing, and then maybe you start to come up with some ideas of what you might design, but you don't really know how they're going to use it. And we just need to be very humble in this process, knowing that whatever we know, it's going to change so much more quickly for young people with how they use tech. So it helps to see how do they use their existing tech, and if you start to develop something, how they're using what you've developed. And there's different techniques that you can learn, which are pretty easy to learn actually, including usability testing like Think Alouds, or even recording them while they're screen sharing using your tool, or human-centered design tools, which there's a lot of training and resources available at the University of Pittsburgh about how to co-design interventions. So some examples of this, like Allison had mentioned, the SOVA website, or Supporting Our Valued Adolescents. This is a intervention I designed during my K. And we have psychoeducational articles. The design process, though, I wasn't really sure what we would do. And we actually had this iterative process where we met with stakeholders, but then this group 2 section, this is when we actually had Think Alouds. So I had built the website and then watched youth literally videotape them, recorded what they were doing on the screen at the same time, asked them really discrete questions like, okay, have you kind of express in words what you're actually doing? Like, I am standing at the podium and the microphone is here, and I think that's spaced pretty far away for me to talk. So literally expressing everything that you're doing, and then it really gives you insight into how somebody is using your tool. Another study that I did more recently with the Etudes Center in Department of Psychiatry. So the Etudes Center, we're developing and testing a lot of different tech interventions for depression and suicidality in partnership with CHOP. And Screening Wizard, or Enhanced Mental Health Screening Tool, is a online questionnaire with in more questions to kind of get at barriers and help primary care providers with decision-making around depression, anxiety. So we did interviews with young people about our screen that we'd started to develop. And on the top bubble, you can see one young person saying, I wasn't completely honest when I first filled out the tablet because I didn't want to get treatment. Like if they asked me if my mood was 1 through 10, say it was like a 1, I would say it was like a 3 or a 4. So adolescents are transitioning into abstract thinking. And so they're having this meta thinking about, okay, what I put on the screen, what's going to happen. And I don't want to enter my real info because I don't want the consequences of that, right? And so what that informed us was that we were going to add messaging before the screen to let them know, hey, if you answer this positively, who's going to find out? It's probably your provider. Most likely you're just going to see therapy. So kind of giving that confidentiality messaging earlier on in the screen. And then we also talked to providers about how they would use this tool. And we thought we would help providers out by telling them like, hey, this kid wants antidepressants. You should probably prescribe antidepressants, kind of giving them some decision tools. And the providers told us, actually, this decision support sets the bar so low, if it does, because of medical legal fear issues that everyone has to be referred. Right now, if I don't get that referral done, now you're making me feel like I'm at risk. And if you tell me to do something and I don't do it, am I liable? I'm worried about that, which is, if I'm going to be honest. So we changed this tool to not give that decision support and not be so kind of prescriptive because of that feedback from providers. And then this is an example of using some human-centered design techniques. This is a fun one. And Mural is the tool that can be used, which has some like free software. And basically, we had youth in our Youth Research Advisory Board give feedback on a research roadmap that teens were getting kind of confused about. What step am I on? What do I have to do now? How do I get paid? And what's neat is that it's hard for young people to talk sometimes, especially in Zoom. They don't have their camera on, but they're all willing to use tech. And so they basically go on here and they pick a Post-it note, and then the pink colors are things they think are good. The green colors are buds, things that they think should get better, and blue are negative things, so things that they don't like. And then they kind of post it like, I like this, I don't like this, etc. And that really helped us make this more user-friendly. Okay, so step 3, this one is a tough one, which is partner with experts. And I would like to encourage you that even though the tech is intimidating, you are also intimidating because of your clinical expertise. There is a lot of tech being produced out there in Silicon Valley and all of the kind of extraneous places without clinician involvement. And a lot of that failing fast, I think, is because of that piece. Because if you don't really talk to people, you're not going to know. So you as a clinician, when you're talking to people in tech, you're representing multiple groups. You're representing yourself and your colleagues, the whole healthcare system, and patients' needs. So what patients are coming to you with, which a lot of people in the tech field, it's like very specialized and unique set of information that we have. And when you're presenting this to tech, I would encourage you not to present it with a filter like, oh, well, I know we can't do this, so I'm not even going to tell them that this is a problem. No, you want to just tell them about the problem and teach them. I've had colleagues who didn't realize that anxiety is a real diagnosis, but thought it was just something like a lay term. So you don't know what they don't know. And then you want to really explain your workflows to them. Like, how is this going to actually be used in real life? And what is your day-to-day like? But then when they talk to you and they're like, okay, well, we can just use an API to send that to the cloud and blah, blah, blah. Like, if you don't understand what they're saying, then ask them and ask them to teach you. So it's like a two-way thing. And it can be frustrating because if you don't do that, there's misunderstandings, but you don't want to spend time and money and then have something useless. So I'll give you an example of that. So I worked with colleagues, Afsana Doreb at University of Virginia and Sam Shaban, who is a software developer at NewRealm. And we had a SBIR grant, which is a small business grant from NIMH, to basically say, okay, can we develop a tool that could be potentially commercialized? And so I would present the problem to them. And the problem was that, patients, parents, clinicians, they have to recognize when symptoms are worsening for depression before they can actually get help. And recognizing that is difficult because one, you're depressed. Two, the parent would rather be like, maybe you're fine. Like, do we really need to go? Time goes by and sometimes people present in crisis. Also, timing for follow-up doesn't really necessarily make sense. So you say, come back in 3 months, but are you really timing that when actually somebody is good? It's summer, they're fine, but they are actually getting worse in the fall. And maybe it would be better for them to come back in 5 months, but that's just not like the standard that we would give. And so the tech solution was potentially using passive sensing, which could be its a whole other talk, but what it is essentially is that your phone is constantly collecting information like, the humidity with all these different sensors, whether the light's on, whether it's moving or in motion. So it can tell you that you're in a car versus walking, et cetera. And all of that sensor information the phone is already collecting can be plugged into these machine learning algorithms and then matched to predict potentially what your mood is. So there's different studies about this. In our study, this is Tassin Malik, who was a PhD student at the time at UVA, and we found 85% accuracy of predicting week-to-week changes in depression scores. And so what that led to was then the next step of developing an app that would integrate and display this data to parents, teens, and clinicians so that they could be prompted earlier without having to self-track their mood. They could be prompted like, hey, your mood might be worsening. Why don't you take a look at your screen time before bed? Is that something you could maybe intervene on yourself that could be affecting your mood? And that would hopefully prompt patients, parents, and teens to schedule early in their trajectory of symptom worsening and self-manage. And then we did a parallel group single-blind RCT with one-to-one allocation of mood ring or usual care, and we randomized 63 adolescent parent dyads with half to mood ring and half to usual care, and we found an average change in self-management score at 3 months was mostly unchanged for mood ring, so a higher score is actually worse self-management, but it had worsened for usual care. This wasn't statistically significant because recruiting the sample was pretty difficult to do. And we found a decrease in depressive symptoms and suicidal ideation in mood ring over time, but no change in usual care. But importantly, there were no safety concerns. And honestly, that was the part I was most happy about because of the amount of effort we put into that and monitoring suicidality and recruiting a population that had suicidality. And most users felt the application had high marginal acceptability. Okay, step 4, that's really important, is thinking about your actual setting. So let's say you've developed the tech, the teens love it, the providers love it, but how are you actually going to implement it in the place that you're going to use it? And it's really important to think will there be human support? A lot of these tech interventions are failing because of lack of engagement. And we're finding that, we need humans. So that's actually a good thing, right? Because we all want jobs and things to do. And what's the learning curve to use the tech? Who will provide the tech support? So this is a neat framework called the NAS framework, and it's one of the many billion implementation science frameworks. But I find this particularly useful because it's specific to digital tech, and it's thinking about, are you going to adopt this tech or abandon it? Is it going to spread, scale up, and be sustained? And when you look at it, and all these different categories are really important to consider. So with tech, thinking about the condition, is it something like an ear infection that's going to happen every so often and be short-lived? Or is it something chronic that someone's going to be seen for every 3 months and they're going to have to do a lot of self-management at home? It's really important to consider those nuances. Number 2 is what is the type of tech? What is the knowledge that you need to use? What is the type of data that's generated? And then there's a value proposition. So is there a demand for this type of tech and can you supply it? And then thinking about the adopters, and the problem with tech, there's multiple adopters. There's the staff, the patients, the caregivers, and then another higher level is the actual organization. So even if the providers want to use the tech, does the organization want to implement it and fund it? Then there's a whole wider regulatory system. So rules about tech and, what is legally allowed in the EU is different from the US and is constantly changing. And hopefully we can have more regulation, but that also adds burden to us. And then the problem is there's multiple circles. So tech is constantly changing. So let's say you figure this out and then it changes next year and then it changes and changes and changes, right? So let's say we build something for Epic today and then Bridges happens in the fall and then we just have to throw it in the trash, right? We don't throw it in the trash, but like we have to plan that it's going to evolve. Like that is just the norm. Okay, so this is a study we did with Screening Wizard, or the enhanced mental health screening tool. And on the left, we did a pilot randomized control trial, and we found some evidence for it that it can increase the number of referrals being made in these settings. And so then I had a medical student who's now a triple board resident at UT Austin, Morgan Corrin, and she helped to do a study where we basically were able to give the tool out to practices that wanted to use it. And I had some adolescent medicine colleagues in different states. There were some UPMC colleagues outside of our system, like in Harrisburg, that were interested in using the tool. And even though the providers said, like, yes, oh yeah, this seems like a really great thing that I'd like to use, there were barriers when they actually tried to use it, which was that it wasn't integrated into their electronic health record. They couldn't really figure out the time needed to screen in their workflow. But the other thing we didn't know about is that each individual organization had a different approval process for using the tech. And they couldn't really they couldn't just test it out, right? And if a drug is FDA approved and it is legal to prescribe, et cetera, the insurance is covering it, it's available at the pharmacy, I don't have to like figure out with all of the different layers of administrative kind of approval processes, can I, as a physician, prescribe that medication? No, I can just prescribe that medication. But if it's a new technology, it's totally not the same thing. It depends on so many multiple factors. So one study we're doing to try to understand this in the Etude Center is the Heart Plus trial, and this is in collaboration with PROS. So Bright is one of the Etude's tools that is really neat. It's a safety planning app developed by David Brent and colleagues, and it also teaches teens about distress tolerance skills. But what we found in the Etude Center studies is that we really thought providers could do this, but we had to use our trained research assistants in behavioral health to help onboard youth. And so we developed another study for peds primary care where we did a training for them about, and we added self-guided tools so that basically teens coming into the clinic with suicidality could just sit down, onboard themselves, and then the provider check in with them later. So hopefully we'll learn whether this process was helpful and some more about implementation. Okay. So the last part of this talk is about partnering with youth. So you've done all of this work, but things keep changing, like I said, and it can really help, even though it's difficult to do, but if we in adolescent medicine are here to help you with this, is to have youth be part of your team. So if youth are part of your team and they're creators and youth with especially lived experience are included, whatever you develop will definitely be a better fit. So on the SOVA website, I started out with having grad students in social work write articles themselves about our topics in psychoeducation. But it was kind of difficult to engage youth and get a conversation going. And so what we started to do was ask youth themselves to write about their lived experience and blog themselves. And then we got really, really neat engagement and articles that youth wrote about their lived experience themselves. So that was a neat process. And then we thought, okay, how can we spread this to other settings? So I got funding from National Institute of Minority Health and Health Disparities to work with youth, mostly of color, who are in low-income settings. So I worked with Boys and Girls Club. And then we had youth. So this is Trinity, who is now at Penn State, but she and Hamna, who is one of my undergrad students, they basically designed a presentation that they could give at Boys and Girls Club about things that were relevant to them around improving employee mental health, because they were getting talks about like, how do I work in different settings? And then they used the SOVA website as content for those talks. And then we did another iteration where, okay, Trinity's going off to college. What are, is someone else going to be able to do this? So we did this rosebud thorn method, and we developed this curriculum to teach youth how do you present about mental health topics and how do you make sure you're looking up information online, considering misinformation and things like that. So that was a really neat process. Okay, so if you are like, hey, I think I want to get youth involved in my research, we have a youth research advisory board in adolescent medicine. And so over the past decade, we've had youth who meet monthly, and they give us feedback, and they give university researchers and even some external researchers feedback about their research. So Dr. Radovic, I think, came and talked to us before about her research and different studies that we helped to recruit for with our colleagues. So on the left lower QR code, you can scan and you can find out more about how to recruit with us in adolescent medicine, or you can email us at kai@pitt.edu, and we can partner with you in hosting a meeting with our Youth Research Advisory Board. And then lastly, Dr. Silva had mentioned that we recently received funding from University of Pittsburgh to design a youth research registry. And so what this will allow us to do, on the left-hand side, we have this kind of self-interest recruitment, and that's kind of one by one asking youth, would you be interested in any of the research we're doing in adolescent medicine? And we directly reach out to youth. So a lot of our studies are around sensitive topics where they might not need parental permission. So we're really asking them to engage with us about their health. But it is difficult, if you know anything about registries, to just kind of start it from scratch without support and funding. And so this will allow us to have the funding and resources to have an ongoing research registry, and then hopefully other researchers can use this population for their studies. And then what was really neat was involving some of our youth leaders. So yours is one of our Youth Research Advisory Board advisors, but then we had Maddie, Madeline, and Jolene and Jay, who are our YRAB leaders and have been working with us all year. And that's that. I just want to thank individuals on my research team and research assistants and all of you for coming today. Thank you.